I just want to, first of all, tell you a little bit about health reform analyses, how they're structured, with using examples from my own article on implementing lean health reforms in Saskatchewan. Great, thank you. I just wanted to emphasize one thing, is the audience for the health reform analyses in particular. Michelle talked about a number of products that the journal produces or will produce, but I'm going to focus solely on the health reform analyses. Clearly, the intended audience is both decision makers and researchers. But the majority of the people producing this will be pure researchers, in the sense largely in an academic environment, although occasionally there will be scholar practitioners that will also prepare these. Because of this, they need to be written in very clear and direct language. There has to be, in a sense, the audience in mind. It can't just be sort of what happened. It's got to be put in the context of its overall importance and its potential impact outside of the jurisdiction in question. So that larger context must always be present. The structure, therefore, is a fairly simple one, but keep in mind that this is a 2,000-word limit, something which I think I exceeded by just a few words this time around, but I'll get better at it. It starts with a brief description of the reform, and in this case, I was dealing with the lean reform in Saskatchewan. I had to describe what it was. I had to go through the language that was being used within government and translate that into a more precise language for the purposes of the article, as well as describe why it was worth doing this in the first place, in the sense of the health reform analysis of lean, why it was worthy of this kind of examination. And that is because, of course, as you heard this morning, when Dennis Kendall was in his discussion with David Blumenthal in the opening keynote, lean really is the single most central reform in Saskatchewan, and most of the health reform eggs have been put into that basket. So it is truly a natural experiment, and it could be replicated in other jurisdictions. Then you have to set out the goals of the reform. In the case of lean, it is a dual sort of objective. One is to reduce waste and therefore cost, and the other is to improve quality and safety and therefore the patient experience. Now, that isn't quite the triple aim. It's missing one leg. But if you assume that reducing waste and freeing up resources allows you to invest more in public and population health, then you have the third of the triple aim. The factors influencing adoption, you have to really be able to pick out from a multitude of factors those that are most influential. I had a short list of those, but among the most important was, of course, the existence of a patient-first review commission in Saskatchewan in 2008-09 that put emphasis on the patient experience, and then the personality of the Deputy Minister of Health, Dan Florazone, who spoke here last year, and his great interest in the reform and the fact that he had experimented with it when he was CEO of one of the health regions in Saskatchewan before he became Deputy Minister. The next is, how is the reform to be achieved, and in this case, through extensive spread as well as intensive training. And in fact, this involves 880 personnel throughout the health system, each undergoing 80 hours of training that is supposed to produce extensive changes in behaviors in the way of in a sense, managing the health system. The next is history and context, and here to be able to distinguish among the most important sort of events or incidents along the road to the adoption of the reform. And in this case, I provided a bulleted list, and among the 8 or 10 bullets, I included something that was in fact a collective agreement between the Government of Saskatchewan and the Saskatchewan Union of Nurses covering the period 2012 to 2014, in which the nursing union agreed to this reform and to, in fact, collaborate and work with the Government of Saskatchewan in the reform, which was quite unique in terms of these kinds of agreements across the country. Next is evaluation. There's been one evaluation on releasing time to care, and there is a process now through the Health Quality Council, through a request for proposals, to basically have a two-stage independent evaluation of the reform. And then finally, a strengths, weaknesses, opportunities, threat analysis done in very summary fashion at the end. So that constitutes basically the structure of this kind of health reform analysis. Now I'll move on to opening this out to the world. I'm going to be acting as associate editor of the journal with liaison to something called the Health Systems and Policy Monitor. This is operated by the European Observatory in Health Systems and Policies, and you can see the website that you can go to see how these are structured. And through our network, Canada will actually be joining Belgium, Denmark, France, a number of other countries which I've listed here. And in fact, there will be a number of other countries joining this platform in the next few months. And my role would be to liaison with the Health Systems Policy Monitor, to work with Michelle in trying to pick out the health reform analyses as well as the other products that can be converted into a format suitable for that international website and platform, so that our understanding and our analysis of health reforms in Canada, in a sense, has that kind of global audience. And I think this is a real opportunity for anyone who wants to contribute to the journal to know that they have that option to be able to slightly rewrite their piece and get it into that format. One aspect of this is that there will be a link back to the original piece in our journal, the Health Reform Observer. So I think this is probably one of the most dynamic aspects of this initiative. And now I think turn it over so that the others can speak to in more concrete terms of their health reform analyses from their jurisdictions. Okay, thank you.